welcome to Grand Rounds. We're glad to have you. And looking out over the names, I see a lot of old friends there, and some new faces that I've not yet met. The purpose of Grand Rounds is to kind of bring the AMEs into what we're doing, what we're thinking, and what's new, what's changed, and give you the best tools to do your job on a day-to-day basis when you're seeing airmen. We're glad you're here, and Dr. King will give you all of the roles and everything as we go through this. But again, thank you for joining us tonight. We know that all of you are busy, but we hope that the information that we give you will be helpful to you and also help you through your practice and also aid you and assist you in saving time.
As an introduction to you folks, I'm not going to be spending much time at all on the actual policy change itself. I'm going to do this is primarily going to be cases to kind of highlight the policy. And just a disclaimer up front about the session being recorded. So just very briefly, again, with the goal of this this policy change with the anxiety, depression related condition dispo table is it's about what we want, what we think you could clear at your level in terms of somebody that's sought treatment and benefited from treatment. So they're in your office now. How do they qualify for Row A? That's what some of these cases that we're going to go through are going to help highlight. And in some situations, how you would decide that maybe you can't. You have to defer. How to use the tools that we've given you. These are some URLs to link through. You can Google. I've tried Googling these same things, and it'll get to FA, anxiety and depression, dispo table, fast track. It'll get you to some of the same things. The main point of this slide to take away from this slide here is if there have been cases that you already have seen as an AME and previously deferred, we don't have a way at the FA level of finding those cases ourselves. So if you happen to go by memory, you're not sure, but you remember the airman's name. Fast track is something that does not. We don't have ability to send out a letter to identify to you the AME record or to the airman they may now qualify for it. So we're really relying on you or the airman if they think that they've seen the policy and think they may qualify to seek you out or tell us, and then we can get them see if they can qualify. This is the decision tool again, and we'll use some cases to highlight it. Again, this is used in conjunction with Row A. When you're actually looking at a case, and just to differentiate, the decision tool here with the fast track here. Again, the fast track is primarily for cases that have already been deferred, but we're finding a lot of AMEs find this tool useful even for airmen that are sitting in their clinic at the time of the exam. As you can see by this differentiating the slides, it's basically the dispo table or the decision tool inside another tool. So if you find this useful, by all means, go ahead and use it. We're not discouraging you from using it, but I would want to point out in the lower right-hand portion, what's highlighted in green. If you're uploading this for fast track consideration, specifically, like you've seen the airman before, and now you want to upload it through AMCS, make sure you tag the right thing in that upload categories: behavioral health, anxiety, depression, fast track summary. That's how we'll get it correctly to the right people. So again, I want to highlight that the main goal of this policy for Row A is you found that something has been treated and is effective, and they meet everything else. We want you to issue. I want you to conceptually take away the word effective in two different ways from this slide. Effective both clinically, that you can find on history that they've received effective treatment, but also from a aeromedical risk standpoint, you think that they have the right risk mitigation is in place, that they don't need a special assurance, basically, and they meet all the criteria, of course. Now, there might be situations where an airman has sought treatment and did not benefit from it, did not benefit very well from it, may have benefited partially. If you're not sure, that's where we want you to put into Row B and defer. One of our docs at AMCD kind of took this policy and this is how we interpret it. And I found it's useful to look at it that way. So they may need further treatment. Maybe they've never had treatment at all. If they've never had treatment at all, then it's definitely row B. So some of our cases will highlight that. But just going back to basics, we're not asking you to do anything we haven't already asked you to do in years past. We're not asking you to diagnose. We're not asking you to do to be a psychiatrist or psychologist. All the same things that happen with other medical conditions obviously apply, right? Many of you that may have seen some of my AME refreshers know that I use the term reverse malingering. That is part and parcel to the nature of your exam when you see an airman. It doesn't matter the medical condition. The best that they're going to get out of that exam is their certificate with you. So they have a lot riding on it. So they want to appear as healthy as possible. It's a natural part of the exam. Again, what we want from you is just your general impression, emotional stability. What does that mean practically? Well, here's a good example of an AME who put in actually the physical exam portion, block 47, some annotations that assist us with that. And she actually noted as abnormal. You could do it there. You could do a block 60. You could do it both. Just something that gives us your general impression, something to go off of. I would say this AME even probably more than what I've seen other AMEs, but we don't need that much. We just need something to help us, right? And this helps again. What we're asking you to do again is not diagnose. We're asking you to risk categorize this individual. So if you're in doubt about row A, don't think about it hard. Defer it, right? Or if you're working up before you're seeing them in the office, you haven't pulled a Med Express yet, the confirmation number. You have time. In other words, you have time to get some clinical documentation. That's your prerogative, just like any other condition. So I don't want to belabor this point too much, but I want to get some case scenarios. And the reason I asked about rules of engagement, I want to leave some time for questions. So I'm relying on Deanne King and her colleague because I don't have a clock in front of me now with the screen share to let me know when is a good time to break for general discussion or questions then. But as we go along, if you have questions on a specific case, raise your hand. We could address it then. I have plenty of cases to go for 2 or 3 hours probably if we did it that way. So we're not going to be short of cases. Case number one, it's not very common individuals go for marital counseling. You might get a history that they've had anxiety related to this marital counseling. They've been in therapy for the past 2 or 3 years, never tried a med. They're not on a medication now. They haven't been on medication for the last 2 years. They're just in counseling. The reason they went to this counselor, it's, again, the marital discord. They also had some, stress related to separating from the military. If they meet all the decision tools in the negative, you can issue. That's a classic example. It's a V code, basically one of the conditions. Maybe the therapist tagged unspecified anxiety in there, right? Again, you may not even have the clinical documentation, but if you get this history and you're satisfied with it just verbally from the airman, you could issue. Here's a little bit of a nuance though, right? You get a different kind of history from the airman. They intermittently had anxiety treated, over a span of a few years. This case, 2008 to 2014. Never used the medication, but it was intermittent, this anxiety. Same sort of triggers. This one, probably more qualified for deferred. You can get into the whole debate about what is intermittent. But if you can suss out from the airman, well, intermittently was the therapist wanted me to come as needed after a certain amount of time. They saw the therapist bi-weekly for 6 months, then monthly for 6 months, and then just as needed. That might be different from, I started to get anxiety, at certain times, then I would go back, and then I'd be fine for X number of months or years. Then I get anxiety. Well, now we're knowing that that's basically what we consider recurrent under the disposition table. So that's why at the bottom I put here intermittent may, qualify as recurrent. If you have difficulty trying to flush out that history, we're not asking you to, again, be a psychologist, a psychiatrist. If you're not sure, then defer. I'll be putting more guidance on this in the next policy change, but for purposes of this, if you trust your gut, if you're not sure, you can't flush it out, then they probably won't qualify, right? That's why we give you the decision tool. There are instances where somebody might be in continual counseling for the same thing. Just I noticed in the first case scenario. Again, if you can't find a recurrence, they could be in chronic continual counseling, right? And there are clinical situations that we see in psychiatry and psychology that may be perfectly fine for medical purposes. I'll give you a classic example I actually saw as an AME myself and psychiatrist, airline pilot, had some depressive symptoms. It was related to a situation with a soon-to-be ex who, during the custody battle, he discovered probably had undiagnosed borderline. But their kids were very young, I mean, the order of like 5 to 9 years old. As soon as his therapist with him discovered this, his depressive symptoms went completely away. But now the goal of therapy was trying to figure out how to approach this ex with boundary issues, because there was definitely a legal custody battle. First, he didn't have full custody, but he finally was able to get joint custody. So he was in therapy for years just to at least manage on a maintenance level how to deal with the boundary issues that would arise as their kids got to the age of adult age. So there are instances where somebody could be in long-term therapy that may still qualify for this. That's the point. So as you can see in this particular case example, this is what the AME noted, the decision tool. Yes to more than one episode, and obviously yes would kick them off and then have to be deferred. Case number 3, we have a young individual, 33, class 2. They're providing you a history of having been on multiple medications, mood, sleep problems. They're telling you they're stable since they've discontinued meds. They tried escitalopram, didn't control their symptoms, so they changed to Luvox, fluvoxamine, but the last time they took meds was 3+ years ago. Is this something that would meet the intent of this disposition table? Technically, no. When they're on multiple medications, that's any history of that would still kick them off to row B. We had to actually formulate a case that met this exactly, but I've seen some similar things like this. If the individual had not been on multiple medications at the same time, let's say they'd been on just Lexapro, it was kind of maybe effective, maybe a little bit, maybe not. So they decide to stop it and change to cross titrate to Luvox. Then it could qualify, right? But we're talking multiple medication, like multi-agent drug protocol use. So just like I was saying, use 2 or more meds at the same time, it would kick them off, but not at the same time. If you get a history that they've gone from one medication to the next, that could still meet the intent of the dispo table or fast track. So as highlight with this one, the current concern with the fast track was that there weren't any concerns, but it would still, this is what we need to see when you send up that information, right? To give you an example of where this would matter on the fast track tool would be this part, would be F8. That's what we're getting at. Having that information, then we can make a determination. Maybe we could, there's no concerns, we'll still go ahead and issue with the warning, right? But we need that history there if you're using it for fast track in order to be able to still provide a good decision on our part if you're using fast track. Multiple medications in this case, like I said, if they change from one medication to the other, different story. Now we get to case number 7, a little bit different right here, right? You might have 2 meds that are concurrently used. You're not exactly sure for how long. In this case, the AME was able to get the history that they were actually using lorazepam for breakthrough symptoms in addition to the SSRI. It was going on for at least 6 months, right? That would technically not meet the intent of row A, so you'd have to defer them. It doesn't mean that we're not going to necessarily turn around and go ahead and issue them with a warning. We may actually do that. That's part of the reason we came about with this new disposition table. is that some of these cases we just want to review first, but I'll have additional policy that comes out within 6 months that will have even further guidance on this. So more to come on that. But for purposes of this disposition tool, if you see what we call augmentation therapy of any type, multi-agent concurrent drug use, you have to defer, even if the other parts are met. So again, where this might fall under, and that's why a lot of AMEs are using some of the fast track, that page one of the fast track, it helps to kind of parse out the row A and a little more detail, getting a history that maybe they were on benzodiazepines, right? There's some individuals that may come to you they've had one or two of those conditions, and maybe the monotherapy that was used was chronic benzodiazepine or low dose antipsychotic, like for sleep. So, especially if you get that history, those would bump you off to row B. But again, the more history that you get, even for the fast track cases, we may have some information that you may not as the AME, and vice versa. This helps to allow us to maybe get to an answer of yes much quicker. Like, for example, not having them go see a community or HIMSS trained psychiatrist, psychologist. We just want to be able to look at that and assess the risk. Maybe they'll get a special issuance out of it and be released within a year or two. Maybe they'll get issued with a warning. Case number 8 here. So an individual, middle-aged gentleman, first class. He'd started SSRI for depression, used it for a few years, had a good response. He stopped it 2 years ago, right? Again, I think I might have a typo here with when he restarted it, but basically he stopped it, and at some point he had depressive symptoms again, so he restarted it. This would be a good example again of what we under the decision tool would call recurrent episode or recurrent symptoms. Even if you glean the history that they didn't restart the medication, but they had a recurrence of symptoms, any kind of recurrent nature of that, or if you're not sure about it, when you're trying to flush out a history, we're seeing some type of documentation, again, that would kick them off to row B for deferred. Some other feedback we're getting from some of our analysts, in this particular fast track that was submitted, the individual, AME, noted correctly, yes or no, right? Just forgot to circle the conditions that apply. If maybe they put in block 60, which would be great. Try and put as much on the fast track worksheet itself if possible. If there's a lot that you need to write down, yeah, it might not be feasible to write it out by hand next to it. You could then put it in block 60, but definitely try to circle the appropriate conditions. The main reason is, like I said, we at the FA, we may have more of a complete record. And so we want to know what the conditions were that you saw here. They may or may not match what we have. That's part of the reason. So here's just an example of a really excellent block 60 that AME annotated, describing some of the history, what who they were seeing for the treatment, how long approximately they've been off the medications, etc. They even found the diagnosis that they found on a progress note, and put in what the code was. Again, the more the better. Right? We understand you're in clinical practice. You have other clinical patients you may be seeing. Just something in there is helpful for us. Again, especially if you're using the fast track method, and there is a lot of information in there, to give us as much as we can to go off of. So it's not uncommon. Obviously, you may come across unlisted conditions. In this particular case example, the AME was taking a history. The airman himself said he'd been diagnosed with depression, and what you get in terms of records, maybe even the pilot, is a history of, they actually say the words major depressive disorder or MDD, either by the airman or the records. The history you get, you're not convinced. Again, we're not asking you to do the diagnosis. We're asking you to gather as much history as you can. But as soon as you hear the words MDD, at least for purposes of this disposition table, that kicks them to row B. Now, again, that's not to say that we might actually issue them with a warning or give them a special issuance, but we want to flush out and look at the whole picture. Um, we've seen that time and time again when it comes to mood disorders. We know that MDD is commonly given as a diagnosis, as an overdiagnosis, but we still want those deferred for now. And like I said, it's not uncommon that you come across non-mood disorders, right? Very unusual ones, neurodevelopmental ones. There, you may not be able to pick up on it all. We wouldn't ask you to. And that's part of the reason on this number one, F1 of the decision tool, we wrote down. So they may be able to tell you that actual diagnosis they had on history. They may not, but we put diagnosis or symptoms such as. This is one of that entire decision tool that gives you the opportunity to to annotate yes to this. You know, if you have concerns that there may be an undiagnosed condition, or the airman's not telling you about something that they were seen for, is telling you that they were seen for something, but they weren't even sure what diagnosis they were given or what the workup was for, or you're just not sure, but you're concerned that it might be in one of these particular things, right? Question of autism spectrum disorder. Uh, this sometimes trips some AMEs up. ADHD that does not meet the ADHD fast track requirements. So to clarify a little bit more about that, in the ADHD fast track requirements, if you find in the workup that they actually meet that according to ADHD fast track, and they meet the decision tool for this dispo table, you are allowed to issue. Now, I know it says in the ADHD fast track, it cannot have any comorbid psychiatry. That's just a mistake on our part. We're trying to recorrect with our next update. But the intent was that if you've done the workup for the ADHD fast track, and if they do happen to have something that's comorbid like this that meets the intent and the requirements of the anxiety, depression, dispo table, then you could issue. So just to reiterate where we see some of these things, you gather a history that may involve some type of clinical depression, MDD, dysthymia, what used to be called dysthymia, that now under the new DSM is termed persistent depressive disorder, or history of seasonal affective disorder, that would kick them off to row B. So here's an example we've had for somebody that used the fast track. Maybe they could, after the fact, maybe this person could qualify. So they sent in a fast track sheet with some of this additional information. Situational depression with the death of a friend, or in counseling for 6 months, didn't need a medication, fully resolved. That was like 6 years ago. They had a second episode with similar symptoms with the stress of loss of a job. Yeah. Any reasonable person would say, well, that could make somebody depressed. That time they were started on SSRI. That was discontinued 4 years ago. No further problems. Again, feel free to use, the point of this is, okay, they submitted this as a possible fast track, but also look at the other dispo tables as guidance. We still have our situational depression dispo table there. As you know, on the anxiety, depression dispo table, situational depression is one of the list conditions, but it still would have to meet the intent of both of these, right? So in this case, it doesn't meet the intent of either one because there's some type of there's a recurrence. So just be cognizant. You can use other tools here at your disposal. Case here, somebody was on bupropion for many years. Their treatment doctor agreed to wean them off of it. It's been they've been off of the bupropion for approximately 15 months. Denies having any symptoms. They haven't tried counseling. Is this an individual you could issue under this dispo table? And the answer would be no, mainly because they haven't been off of it for 24 months. Okay. Right now we have that set at 24 months, 2 years. That doesn't mean we might not turn around and issue them with a warning or provide them a special issuance with maybe some short-term monitoring um, by their PCP, maybe if they haven't been in counseling. Or if we get a history, maybe they started seeing a counselor and they're not now. Maybe, it depends, right? Again, row B is for those instances where we need to make a little more assessment on what is the air medical risk and how to manage it, right? Row A is basically saying they can manage until be seen for their next AME exam. So again, that depends on their age and the class of medical that they're requesting. Um, but if you're in doubt about whether the risk assessment can be that's the purpose of row B, so that we can figure that out. So again, that would be again number 8 on the decision tool. Use of any medication has continued during the last 2 years. Dan, how am I doing with time?
You are doing great. It
Okay.
is 7:30 Central
Okay.
Time. So,
Okay.
and you're on 11 of what, 13 cases. So let's go ahead and if we leave 15 minutes for
Okay.
questions, we're good.
Trying to go through these fairly quick, but if I'm going too quick, let me know.
Nope, you're good.
We get a common question we've been getting now about, especially the fast track. So it's not uncommon. Individuals obviously seeing you as airmen might have more than one condition, right? So they might have some type of mental health condition that may or may not meet the fast track, previously deferred, but now they have something else, right? Sleep apnea or some other condition that needs its own workup. So they actually, in this particular case, they were deferred due to recurrent episodes on the decision tool, but maybe they might meet the criteria of fast track, and otherwise we would go ahead and issue them. But in such cases, if they have another condition like a cardiac or sleep apnea that needs some type of workup, um, we would send out a letter accordingly to that. But that's for your awareness that's been happening, and our analysts are fully aware of that, and that's why they would be the airman and the AME record would be getting a information request letter. Just so you know, if you see the letter and you're confused by it, it's because we may have more information you do, or it might be another condition that's actually keeping us from being able to issue them right away. So getting to a little more of a complex case here, first class applicant, young male, has a history of OCD. A few years back, that's when his symptoms peaked. He had some thoughts of suicide. Not exactly sure what kind of thoughts, but he did seek help from a therapist. Tells you that he's no longer had these thoughts since. AME reports that goes to the decision tool. Would this individual be issued or deferred? This is where using the decision tool that we've given you is very, very critical. OCD is one of the listed conditions, but in this case, you definitely want to go through the decision tool very carefully, right? In this case, any lifetime history of suicidal thoughts, right? Even if it's passive ideation, they haven't had it since. Right now, we want those deferred. We want to be able to collect data on those. We want to make sure that the right risk assessment is being done. It wouldn't, again, the FAA, we're reserving the right to review this kind of case. Given the length of time since, he sought treatment. If we review the treatment records, we might feel totally satisfied that this individual could get away with even a warning, right? But we need to review those a physician at the FAA needs to review those, possibly with consultation from one of us in psychiatry or psychology. Again, the history is critical here. So that would kick them off to row B. It's not to say, again, like I said, they might get a warning or they might get a short-term special issuance, but we want to reassess that risk assessment. Another complex kind of case, individual was diagnosed depression, bipolar 2 is considered in the differential. later dismisses a diagnosis. You gather history that they've had prior episodes of depression. They've been treated with, they've been treated at least 2 antidepressants, bupropion, Wellbutrin, escitalopram, Lexapro. They also tell you that they were using Abilify. They admit to a history of internet gambling they were struggling with. You see some documentation that they've not followed through with prior special issuance instructions. In this case, the AME sent a favorable fast track tool and all criteria in the no column. As some of you might be very astute, this history obviously would not be concurrent with the fast track tool. And this is why. And this is why some AMEs are using this system with just the dispo table itself, right? Any history of neuroleptics, antipsychotics, that should raise a red flag that maybe the history isn't as simple as is suggested. I mean, granted, we've seen in clinical medicine, primary care physicians and mid-levels using neuroleptics for just insomnia, even when there aren't significant other mental health symptoms. But we want those deferred for now. So in this, but especially the fact, I mean, there are prior episodes here. Apparently, they were on some type of SI. But especially that what I want to highlight here is that itself, just the fact that they've been on aripiprazole, generic name for Abilify, that should be a red flag to you. So again, if you're in doubt, you could even submit the fast track saying you're not sure, right? I myself did that as an AME with some of the decision tools I was faced with, and I'm presented with the history, and there wasn't time that I could send them for a workup or get a specialty physician exam. I would put unsure. You can do that for a decision tool. When you're unsure, obviously there's a critical part, or there's a question that we always have. And if you guys know, decision tools number 9 here, it's usually one of the questions in most decision tools. You have any concerns? There's always a way to use an AME, even if technically they met all in the no column. Use an AME still have the right to always defer. But I just want to point out the fact they were on Abilify, that itself should be able to kick them off. Another complex case that we've seen, there's less instructions on the decision tool, as you can see, and some more guidance on the fast track. So that's why we're seeing some AMEs use the fast track because it just flushes out some of this a little bit more, which is fine. Individual, 47-year-old, third class, reports a history of OCD, a lot of psychiatric comorbidity. That it's common that we would see together. OCD, anxiety, depression, that triad's common, not uncommon. They also report ADHD. Okay, and clinically, I would look at that, and as a psychiatrist, and I'd be flushing out: is it true ADHD, or is it focus and attention issues due to untreated OCD? It's a common consult question that we get in the mental health world. Well, fast track, gives you a little bit more that would help you to kind of flush out for yourself how much do they really meet the intent of row A of the disposition table, right? You can actually circle the conditions here. And just the number of conditions itself means you don't even have to go through the entire decision tool, right? You can circle them and see, well, they have 3 or more. OCD, anxiety. Don't think about it too hard. Don't try to redo the math, right? They're reporting these things. Again, we're not asking you to get to the exact diagnosis. That's what we'll do, or get treatment documents to figure that out on our own. Do they really have just OCD, secondary anxiety, depression, and no ADHD? We'll figure it out later, right? For purposes of aeromedical disposition, using the fast track sometimes helps you to, oh, yeah, I circled this many. That's 3. Well, we know that they wouldn't meet the disposition table to begin with because it has to be 2 or less. This is just a little more information on that, why the AME deferred it. again, just a few things I've mentioned already before. If you end up you identify a potential case, airman that you've seen before that may qualify for fast track, just uploading the fast track, you have to actually go yourself to the internet, to the AME guide or to our website and download the fast track worksheet. There's no way that we have a way of identifying the airman ourselves and sending something to use the AME record. The airman would have to contact you to say, I might be a potential case, or you would have to know it from your recollection or clinical record, if you've kept track of that, and then go and find the fast track worksheet and then fill it out. And then the next step, of course, would be going into AMCS, looking up the airman by some fashion. If you have a MI, application ID number, the birth date and name, and then finding the right place to label it as a fast track summary. That way we can actually tag it and look at it correctly. If those things aren't met, we just can't work that current process to identify them. So I've gone over a lot of stuff. I want to leave time for questions. Basically use the fast track, just a summary, use the tools that we've given you. We love feedback on the tools. You've already gotten some feedback. We might make some minor editing changes to it, but we definitely make changes when we see feedback. So give us that feedback. Just the basics on the disposition tool. Keep looking at those. Look for recurrence. Leave it open for further discussion questions.
I always will put in a shameless plug for if you have ways to improve the AME guide. This is the mailbox you can use. It's a joint mailbox, and we're happy to take your suggestions. So thanks everybody who has responded. We're working on those as we can get to them. Thank you.
And just for everybody, I'd like to thank Dr. Danzig for taking the time and sitting here in the hot seat and sharing real cases from what we see every day, and also just for the willingness and the openness and just being part of the team. So if we could, please give him a virtual round of applause, and thank you, Dan. Thank you very much. Job well done tonight.